Okay, it's 1 o'clock. Hey, welcome everyone. Welcome to Healthcare 2020, Connecting the Dots with Dave Racer, an event sponsored by the Heartland Institute. My name is Jim Lakely. I'm the Vice President here at the Heartland Institute, and it's nice to have another event. COVID-19, normally the Heartland Institute has 1 or 2 events a month here in our office in Arlington Heights, Illinois. And obviously COVID-19 has changed the way we can do that. In other words, it makes it very hard to do it. And this event actually was originally scheduled, I think, yes, for March. We postponed it, hoping to have a live event here in our office, and we were not able to do that. And now here we are, July 15th. Very happy to have Dave Racer with us, but making sure that we're all safe and that everybody is staying healthy, we decided to do an online seminar this afternoon, and I welcome you all here and very glad that you are here. Your time is valuable, and so we're going to get started here. I'll be monitoring the chat room. So if you have any questions during Dave's presentation, you can put them there and I'll help, I'll read those questions and help direct the Q&A with David when he is done with his presentation. And also email us at think@heartland.org so you can let us know how this went and what other kind of events you would like the Heartland Institute to stream here from our offices in Arlington Heights, Illinois. With that, let me introduce our speaker. Dave Racer is a Heartland Institute policy advisor on healthcare. He is presently a member of the Minnesota and National Association of Health Underwriters. Dave also this year became a board member of Freedom's Dream Foundation and served as a board member of the Minnesota Physician Patient Alliance for many years. In 1986, he wrote his first book, Smokey's Last Job, and in January of this year, he released his 50th book. And among the latest of his books is what we're here to talk about with us today. Dave, along with Greg Datillo, recently released The Manual, Healthcare 2020, Connecting the Dots, which is the blueprint for a new approach to total price transparency. I'd like to now turn over this digital gathering to our guest speaker today, Dave Racer.
Well, what a great day to be with you all here from the epicenter of civil unrest in the Twin Cities of Minneapolis and St. Paul, Minnesota. Whoever saw that coming? On top of that, COVID-19 that has disrupted our lives in so many ways. Government spending that seems out of sight, new discourse on climate change. I mean, the list goes on. And in the middle of it is healthcare. And right now, what folks are most concerned about is, will it be there? And later on, they'll talk about how much it costs, because that eventually will come up. And of course, presidential politics, all of that. Healthcare is the issue that never goes away. And so we thought it would be good to take a time out and to talk about an issue, what we call Healthcare 2020, doing what actually works. It's a little bit arrogant to make that claim, but it's time perhaps that we go to some more grassroots kinds of solutions. And that's what we're going to talk about. Why is healthcare reform so hard anyway? And we talk about this a lot in detail in the manual Healthcare 2020, Connecting the Dots. And we're going to show you how to get a copy for free from Heartland. It's not a long read. It's less than 100 pages, 4 hours of reading, and you can learn a ton. And so we talk about connecting the dots because we see that today, the dots, the various parts of healthcare are disconnected. So first of all, you have providers who provide all the care, you have the payers who pay for it, you have the government that regulates it, and they seem to know what each other's doing. And then somewhere out here, we find the patients and the employers who are the ones that are paying for all of it. And instead of this, we suggest it's better to line the dots up this way with patients, employers on top, making the decisions that drive the providers, the payers, and government in that order. And so even though it's not a political document, it does make a statement about how we need to realign the dots so that patients actually have a voice. What we're doing here, and I don't mean to offend anybody on this call who happens to be a policy wonk. I love policy wonks. I love talking to them and I learn from them. We're saying we're bringing some common sense and grassroots knowledge to changing US healthcare because most healthcare reform is proposed from the top down. I remember, and I say by well-meaning nonpartisan experts, I remember reading a book by a Harvard professor years ago, a fellow who makes $100,000 a day as an expert advisor. And he's the guy that was kind of the champion of value-based care. And I thought, I wondered if he's ever called on a patient or called on a client, spent time with an employer. And it is a very, very highly politicized subject, of course. And we know that the Democrat caucus and Republican caucus and the independents and the libertarians and everybody has their well-meaning manuals of how to revise healthcare. But they're politicized, and that's a problem. And so we're trying to offer a different voice, a pairing of what we say practice experience with communications, research, and broad exposure. And just for a moment, I want you to meet Greg Detillo, who is my co-author on 5 books now on healthcare, 45 years as a business and individual insurance consultant, helping people in the trenches, not in theory, but what they actually want, what they actually experience, much like a family practice doctor, a little different opinion and view of how healthcare should be restructured. And by the way, if you want to get to know me a little bit better, you can go at simpledaveracer.com. That's all we need to say about that. So what we're going to do is propose what healthcare consumers actually want based on the issues that touch them every day. And we're talking about not theory, but practice. And let me give you an example. There's a theory out there that if you limit the amount, or if you build in incentives, the insurance company is going to want to cut the price of healthcare, which absolutely makes no sense because the law says they get 15% or 20% of the premium for all of their costs. Why in the world would you think they'd want to cut the premiums? That makes absolutely no sense. It reduces their company's revenue. So we have to do it from the bottom up. We have to make a price demand on them. And that's what we're going to talk about today. Briefly, how health insurance is distributed throughout the United States. And like statistics everywhere, these are 2018. The numbers have changed actually quite dramatically with Medicare, which is up quite a bit. But we have to have a reference point here. And what we do in the manual, we don't really talk much about Medicaid, Medicare, or other government programs. Our whole point was to focus on private insurance and what's happening with the people who pay for their own health insurance premiums and their high deductibles and their high out of pockets. And so most of what I'm going to talk about today is going to refer to privately insured individuals who we say are kind of forgotten people. And it's really time to focus on them. And this number, 218 million, if you keep up with healthcare, you'll know that number sounds out of whack. That's actually the number out of the 2018 Census Bureau statistics. So there's a lot of overlap, and that makes the numbers hard to follow. But these are working people. They're employers. They're people who actually pay for their care. And according to Kaiser Family Foundation, last year, the average premium for a family in an employer situation is over $20,000. And I can tell you from absolute experience here in Minnesota, down in southeastern Minnesota, where Mayo Clinic dominates, the premiums have run $30,000, $35,000, and even $40,000 a year. That's crazy. It can't go on. It's got to change. We have to find answers. Another thing we've learned in all these books that we've written on healthcare is how hard it is to even share the story because it's complex and everyone has his or own story. And healthcare is so personal. And even when here today, when I'm talking to you, you're going to say, yeah. And then you're going to say, but in my case, or in my uncle or my kid or my cousin, this and this happened. And how are you going to handle that? That's what makes healthcare discussion so difficult. So we're going to try to focus on ideas that connect. But understanding that underneath all the stuff we're talking about today, there's a lot of research, a lot of backup data, and taking into consideration the realities that you and I face every day, even in our own healthcare consumption. The thing is, we who take a more conservative point of view, I think we're wrong, even though we're right. I mean, if you look at this, we know that all of this area needs work. We have to reform a lot of stuff. So it's complex and we're right. It's just that the message is so complex. So another side, the more liberal side, has a simple answer. It's wrong, but it's a simple answer. Vote for us for free healthcare. We probably will disallow some of that here today. So one side's winning play in the political conversation is bringing back this idea of pre-existing conditions, that somehow one party is going to take this away and another party is not, and they enlist fear. And it's really hard to get past this. But here's a factoid not many people have thought about. One political approach that's very popular, and Bernie Sanders, of course, was out there with it, and the people who are following him, and maybe even Mr. Biden, I'm not sure really about that at the moment, but they talk about Medicare for all. Medicare for all, or a public option, something like that, where the government is a key player, or actually another name for single payer. If you really want to talk about it, it's going to go that way. That's the direction they want to go in. So think about this. What health plan in the world brings back pre-existing conditions on nearly everything that's chronic or serious or requires a surgery that can be delayed? Is a single payer healthcare system, because they have to ration care. They have no choice but to ration care because there's only a limited amount of money to go around. So those who want single payer or other forms of government run healthcare, we assert they are the ones who want to bring back pre-existing condition exclusions. So we think in 2020, a new answer is needed. So this is kind of a fun graphic. We've used it many times before. If you want government-run healthcare, we can do it really cheaply because we can buy a lot of canes for $15. But in the United States, we become used to something a little bit better. And market-based healthcare can give us so much more. And this is just a symbol of the difference between the two forms of healthcare. Yes, market-based healthcare in the United States is very expensive. That's our goal. Can we reduce it? Is market-based healthcare even possible? Because our detractors say that it can't be done. You can't create a real marketplace. Well, you can't if you don't have a price point. That is true. We have to have clear price points. And that's what I'm going to talk to you about now. So Healthcare 2020, this idea is actually already drafted into legislation. In Minnesota, we've worked with the legislature to draft several bills, and these have all gone on to Congress. We hope to be down there shortly again talking about these. First of all, a simple, easy to use price transparency, something so very, very important, and I'm going to spend a lot of time on it today, is the Medicare percent. That'll create a patient-friendly marketplace where the price of care is known before you buy it. We need to eliminate open-ended promise to pay contracts. And think about it, every time you go to a provider and you sign that statement, it says that you are liable for everything that your insurance company doesn't pay, but they don't tell you how much it is. They don't even tell you the basis for charging. You just sign it, and you are the one who is going to be stuck if the insurance company doesn't pay the balance. We want to put an end to that. We want to quit forcing private insurance and patients to pay hospitals and other providers for their own mistakes, for acquired infections, and reducing premiums and increasing the quality of care. And lastly, in our package is to allow for new, less costly comprehensive health insurance policies. These are known as reference-based pricing policies. I am going to spend a little time on that in this presentation. So think about it. Today, who knows the price of care? Providers do. They are the ones who, do the billings. The payers do, because they're the ones who pay the billings after they negotiate and so forth. And government, who regulates it, they know the price of care. The ones who don't know the price of care are patients and employers, the people who are paying the premiums. We want to change that. So we are offering a concept that we think is a little bit different. We're trying to get it into the vernacular, called the Medicare percent. This quote is right out of the manual, Healthcare 2020, and it's a little bit, like definitions, a little difficult to follow, but it's the percentage related to Medicare's reimbursement rates a provider will accept as full payment from private non-government health insurance plans. In other words, it's how insurance companies already determined how much to pay for almost all of the things that they reimburse as a percent of Medicare, not negotiating every single one of those CPT codes and other codes. No, a percent of Medicare. And so in Minnesota, I have to tell you, Tale, this is pretty wonderful. This is on page 79 of the manual, and you'll find it there. We worked together with a couple of legislators in 2017 and 18 to pass a price transparency law. The law that we proposed, and literally Greg and I wrote it, and it didn't end up the same. Of course, you know that never happens. But what passed, get this, passed 165-0 in the House, 65-2 in the Senate. Yes, we have a lot of legislators in Minnesota. And so it's amazing that it passed by such wide margins, and that's because price transparency is very, very popular. Now, let me explain how this worked in practice. In Minnesota, if you're in a family practice clinic, OBGYN clinic, pediatrics clinic, you can walk in and there's a chart on the wall, and it will have the top 25 procedures, and it will show the Medicare rate, the average reimbursement by insurance companies. It'll show the billed price, what we call the charge master fake price, and it will show the Medicaid price. So now we were able to go through and we collected these charts from across the state. I did this analysis to calculate the Medicare percent of these 23 providers. This is not all of them, of course. You'll notice at the top of the list at 282% is Mayo Clinic's Rochester Primary Care Clinic. Amazingly, they have some other clinics where it's a little bit less, but this is the Rochester Clinic. Essentia Health, located out in west central Minnesota, is about 200%. There's a little town in greater Minnesota called Medelia that's at 109%. I'm going to demonstrate what that means even more clearly in a second. 201% average Medicare percent across Minnesota. Now, the fact is, if you take any procedure in Minnesota where there's one reimbursement zone for Medicare, all of these providers would get $100 for the same service for someone on Medicare. So we use that identical measurement, the fact they're all getting the same, to calculate the Medicare percent in each clinic. So now we know that for a procedure that is $100 from Medicare, Rochester Mayo gets $282. Essentia West gets $199, Medelia gets $109, and the average across Minnesota is $201. I realize this is Minnesota data, works everywhere. Same thing. Some states have more than one CMS reimbursement scale, so it's a little more complicated, but Minnesota's simple in that. So here's how it works in practice. Let's say you have a 40-year-old who is out looking for a new clinic, just moved into town, or is tired, or their doctor moved, or retired, or got bought up by a large health system and she doesn't want to go there anymore. So with the Medicare percent, here's how she can shop. She can pick up the phone and within a few minutes ask the same question of these 4 clinics. What percentage of Medicare do you accept as full payment? The Southwest Clinic, they say, well, because the law is requiring them to do it, 125%. Southeast Clinic's at 150. The Northwest Clinic, a little fancier strip mall, 200%. And the Northeast Clinic in that 16-story tower with pane glass up and down, fancy, you know, it's got the piano in the lobby and the waterfall, they get 300%. Now she's in a position to say to all of them, why do you charge what you charge? How come you charge 200%? Why not 150%? It puts her in that position. So let's see how that translates with money. We take a Medicare reimbursement at $153. Here's what it looks like. At 125%, it means the clinic is getting 191 on average from insurance companies they're accepting as full payment. That's what we're saying. $229, $306, and $459 for the same service by different doctors in different clinics. Actually, it's possible one of those doctors works in more clinics and is getting the clinics getting more at the other one. That's another part of the problem. We addressed that in the manual. So Why would anybody want this disclosed? Well, we think the providers would like to know, the patients would like to know it because it gives them a chance to shop. And you say, well, what are you doing if you're in an ambulance on the way to the hospital? There's nothing you can do. Absolutely true. And we have a provision for that to max out payments. There's a way to do that. But 80% of healthcare, 80% of spending is shoppable. You can shop for diagnostic services and lab tests and primary care doctors and surgeons and surgical facilities, inpatient and outpatient. If you want to take the time, you can shop. And so it allows providers then to compete on price as well, because the hospital, this is regions, will know what Hennepin General is charging based on their percent. It allows for a patient-provider conversation about price and quality. Now the patient can say, why do you charge so much? Why is Dr. Jones over there charging half of what you charge? So we think it's a simpler way to price shop, to establish a price point. So providers will win as they disclose their Medicare percent. They're going to push back, but they're going to win in the long run because they're going to escape government price setting schemes. The government cannot come along like they do with Medicare. If we get a Medicare for all plan and say, here's how much you charge, or if we get a public option, believe me, in Minnesota, where they've considered public option, I can read it to you from the language of the law. It says the reimbursements will be between Medicaid and Medicare. In other words, even less than Medicare. How many providers want to have to live under that regimen? So it will allow them to escape government price setting schemes, allow the market to set the price instead of government bureaucrats, allow them to see their competitors' Medicare percents, where they can practice independently if they choose again to leave the hospital systems. And it creates a patient-friendly healthcare system. So it also allows for a new affordable form of health insurance. And some of these are already evident in parts of the country, but most not yet. Insurance policies that offer a different predetermined Medicare percent provider reimbursement. For example, I might buy a 250% Medicare plan. You might buy 125%. Jim might buy something else. It offers different premiums for different budgets determined by the Medicare percent that the individual chooses that the health plan will pay, because the health plan will pay up to that percent of Medicare. Now, please understand, we're not talking about Medicare price setting here. We're talking about individuals buying a health plan where the reference price is Medicare, but the provider can set their price wherever they want it, and the health plan will pay up to that percent. We can talk about in a minute, we will, about what happens when those are different. It engages patients in shopping for providers based on price. There are, listen to this now, no networks, none at all. This is truly health insurance, the kind that can be used across state lines, where in the states they protect their territory with networks and other kinds of things. No networks, any willing provider. It is more affordable, there's more freedom, it creates a friendly marketplace, and most importantly, puts patients in control. Now, I happen to be almost 73, and so I think this is an accurate picture of me. I still have more hair. But I do this to demonstrate something for you. This fella, if he is going to get that $153 procedure done at any one of those 4 clinics, guess what? He has his pick. If they accept Medicare and they want a patient, they're going to all get $153. Now, that 40-year-old who bought that reference-based plan that pays up to 150% of Medicare, she's going to want to call around and find out who is closest to that 150% of Medicare, because her plan is going to pay up to $230. And you remember from the other, well, you probably don't remember, but I showed you the data before. At 150%, the Southeast clinic is going to be the one that's the closest. She may choose that clinic because it's also the one where her best friend goes and she loves the doctor there. Or maybe she won't because, you know, another friend goes to the Northwest clinic and gave her lots of reasons why she'd want to go there, and she's willing to pay the difference. But the point is, it's in her hands, not in an insurance company's hands or a government's hands. It's in her hands where she goes. So what the healthcare 2020 plan will do overall protects Americans from single-payer healthcare, bringing back pre-existing conditions. It'll protect the 57 million Medicare enrollees today from Medicare for All, diluting their benefits. If we add 275 million more people to Medicare rolls, holy smokes, there goes our benefits for those on Medicare. And the answer is to add $32 trillion in spending. And you have to say, where's that going to come from? You're going to have to set up rationing. And who's it going to hurt the most? It's going to hurt people with pre-existing conditions. We want to protect 218 million Americans from single-payer healthcare, taking away their private insurance. We want to protect this 57 million Medicaid enrollee is now flipped. It's about 75 million, but we're not going after them in this particular presentation. And I don't even want to say that we're ever going to go after them. I think there's a lot needs to be done with Medicare and Medicaid. We don't address that in this plan. We are addressing the private health insurance marketplace. And what we want to do is create a patient-friendly marketplace that thrives on simple price transparency, that drives competition, that fosters quality of care. So this is what you call more than even a 50,000-foot review. It's probably more like a 200,000-foot review. But you can go deeper, and it's really, really easy to do. The manual Healthcare 2020 is an easy read, believe me, but full of data that supports the kinds of things we're talking about here, so you can have a reasoned discussion about it. Send an email to think@heartland.org, and they will give you a free copy. They'll send it to you. If they run out, we'll send them more, and then they can send it to you. A couple other things I want you to see that are in the manual, and then I think we're ready for questions. We talk about something called the hidden tax, and that's what you don't see. This is not payroll taxes, not income taxes. This is what you pay because the other health plans, the government health plans, pay so little. We call that a hidden tax. We analyze networks and the price secrecy that they create and the price disparity they create and the complexity of pricing that no human being hardly in the world except a billing coder can understand. And so this is what creates all those different prices, even in the same providers, and it's so perplexing. And we talk about the lack of competition in healthcare and the patient-unfriendly marketplace with its open-ended promise to pay contracts, and how hard it is for any patient to know whether they're in network or out of network. Have you ever thought about that? I mean, a provider says to you, go and find out if this is covered. And you have to go and call your insurance company and give them the description of some surgery that sounds like, a Greek textbook, and you don't even know the words, and you're supposed to find out if it's a covered expense. So we think there's probably a better way to do that. Hard to know if specific healthcare services and products are covered, and having to pay twice for provider acquired illnesses. Now, certainly modern technology has increased the price consciousness, and you know that the Trump administration has ordered hospitals to disclose their prices. I wonder if any of you have looked at that long list of prices. It's very complicated. It also doesn't tell you much about the hospital or much about the doctors and so forth. So we talk about patients sharing information with each other about their providers. And yes, that can be a little frightening for the doctors, but it's also frightening for other people that provide services and products. We talk about the mandatory percent disclosure. We talk about the patient-friendly marketplace where patients can choose his or her own doctor across state lines if they choose. They can have easy access to useful provider information, including patient reviews. The patient can know the price before receiving care. There's no surprise billings, exposing price gouging, protecting when the patient is the most vulnerable, and doctors and hospitals competing to provide patients with better care at lower costs. This is what we propose in this concept in the manual Healthcare 2020, Connecting the Dots. Again, read it at your own pace. Write to think@heartland.org. Be sure to do that and get a free copy. And then here's the other thing. If you want to know more, you want to ask me directly, my name is Dave Racer. I have a website, daveracer.com. My email address is dave@daveracer.com. It's very, very easy to get hold of me. We have a website at the Manual Healthcare 2020 patient-friendlier.com. Does this answer everything? No. It is an approach to a simple price transparency that we believe is necessary to get the ball rolling to create a patient-friendly healthcare marketplace, which we desperately need. Jim, any questions?
Thank you, Dave. Yes, actually, we do have some questions here. And it'll encourage our attendees to you can either put them in the webinar Zoom chat, or you can go into the Q&A section, which some people have already done, including Larry Greenberg, who is it's good to see you, Larry, on this webinar. He's a regular attendee here at our office events in Arlington Heights, and so I'm glad that he is on with us today. But he has a pretty simple question for you, Dave.
Sure.
If a person uses more than one provider, who has access to the patient's records?
Well, that is a very excellent question. The patient ought to have access to the patient's records. Right now, physician one has the records. Physician one should share them with physician two when the patient requests it. We believe there needs to be a way for patients to keep those records, take them with them. We didn't write about that in Healthcare 2020, but we're not done writing. So Larry, thanks so much. It's good to see you. I think you're there somewhere. So
excellent. Okay, we have a question here from Kathy Scrotch. She says, how does the classic declaration, quote, above the usual and customary charge allowed for this provided service, unquote, fit into the Manual Healthcare 2020 proposal of yours?
Well, what we're proposing is, first of all, price transparency so the patient can see. So it doesn't really relate to that at all. It's what the provider will accept as payment, average payment, if you will, from insurance companies today is what it is. But what they will accept as full payment as a percentage of Medicare. So it doesn't apply to that at all. If I can give you some statistics out of the RAND study, where they found the average across the country was 165% for clinics and 241% for hospitals, inpatient and outpatient. That was an average. So that number is not relative to usual and customary. It's what they actually accept. And that's what we really want. The idea of reference-based planning can actually designate a difference between clinics and hospitals. It can even be adapted for diagnostics, but so it's not going to relate to that. The health plan, the reference-based plan, will set the max at 150%. If the physician or the hospital wants to charge more, that's a negotiable thing. It's not related to usual and customary.
Okay. Thanks for that answer. David Block has an answer, or I'm sorry, has a question for you. How can medical records be shared between states and entities that are unrelated?
David Block, wow, what a great name to hear. I wish I could see you. So across state lines, sharing health records, I think it's kind of a touchy concern for many because of, well, not even HIPAA, but more privacy and so forth. Again, we didn't do that in Healthcare 2020, and I would accept the challenge. I know Greg Datillo would, to think that through and do some writing on it. We just haven't done that.
Okay. A question from John Taylor, and then we have a question from Mike Reichus coming up right after that. But from John Taylor for you, Dave Racer, how do you propose addressing the problem of third-party payment for what should be first-party payment services, i.e., you are still using insurance for primary care, which can be low cost and does not need the middleman, when it's better used as true indemnity for catastrophic or emergency care?
Yeah, and that's actually a plan question because these plans can be written to accommodate that. I'm going to be 73 in September, Lord willing, and I go to a cash practice doctor because I choose him and he is so excellent and he saved my life and all of that good stuff. And so I can tell you for sure, I will fight for our chance to use that sort of thing. To have a catastrophic plan that's based on a Medicare percent is very, very possible. So it goes more to plan design than it does the concept itself. But a great, great question.
Great, thanks. So here's from Mike. What is the argument against RBP or Medicare percent pricing? Why wouldn't someone want this?
Well, it's probably more on the provider side because it's something that they have to get used to. It's something new, and because it's fully disclosed, they're going to be watched by their competition. That's scary. For individuals, here's the fear. You go to the doctor, you go to the hospital, and they won't accept your insurance as full payment, and they'll want to negotiate for a higher rate. I'm going to tell you a true story from Minnesota. This whole RBP thing is growing. Some of you live in states where it's already happening. Here in Minnesota, it's just getting off. So going. And so Greg had a client, and I'll be careful not to share any data too much here, who had a emergency heart procedure and had 140% RBP plan. And the hospital billed $95,000 for the procedure. Medicare would have done it for 44. I mean, that was the Medicare reimbursement. The hospital would not accept 140%. They wanted 100%. And the reasoning they gave, and get this, I mean, here's where you get into technicalities, was that he was out of network. Well, of course he was, because there's no network with an RBP plan. So Greg went up there as his advocate, as an insurance agent, sat down with the hospital administrator and said, what is the matter with you? If we had a conventional plan, you'd get about 55,000 and you want 95. And they said, yep, that's our policy. Greg said, wait a minute. He turned the recorder on. This is absolutely blows your mind. And the guy kept saying, that's our policy. That's our policy. And they're going to go after this guy for the whole amount. They don't care. Well, that's got to stop. We think that as the RBP system matures, and I know a lot of them are at 130%, by the way, on clinics. We know what Montana did. Montana went out and negotiated this with their state employee systems at 232% for hospitals. And it was a real battle. We write about that in the manual. That alone is worth the free copy. So I forgot the question. I got excited there. So.
Okay, actually, here's a related question to that from Karen Crotty. She types in, here in New Jersey, I am selling RBP. The carriers seem to be the roadblock. Do you have any comment on that?
I have a comment on Karen Crotty. Good to hear from you, my friend. Yes, I have a comment on it. I think that it's going to take, as it always does, an army of health insurance consultants, brokers, and agents to propagate this insurance so that the carriers have to respond. We have to find carriers to come into the marketplace. In the manual, we show, if this doesn't blow your mind, I don't know what will, 5 carriers have 82% of the employer marketplace. 5 carriers. We need more. So I think that the agents are the army. I've always said that. That's why I like talking to agents, and I need to go to New Jersey, by the way.
Yep. I'll remind our audience here that if you want to ask a question, there's a Q&A button down there for you, and you can also just go into the chat, and I will ask the question of our guest today, Dave Racer. But I have a question here, Dave. Obviously, you've been with the Heartland Institute as a policy advisor with us for several years, and it's been a fantastic relationship. We've learned a lot. It's a good networking for you to talk to other free market advocates for healthcare, for getting more free markets into the healthcare space. And what I guess what I'm asking here is that, there's been a lot of talk about this for a long time. It seems it's so logical to have, to use free market forces to bring down the cost of healthcare and to improve the quality of healthcare. I mean, free market forces do that by definition in every other field in the United States. accept healthcare, because, I'll joke sometimes to people who don't know this policy or don't know this this policy area very well, and I advocate for free market healthcare. And I say, well, it would be great if we tried it once. For most people alive today, they've never really known a true free market for healthcare. I wonder if you can talk about, I guess I'm asking you two things. Why has it been so hard to get free market forces to work in healthcare? And do you think with the passage of Obamacare, even though it's starting to come apart and isn't quote unquote working, it seems like this is a mud pit we're never going to be able to get out of.
Yeah, I guess I'm tempted to just say politics and be done with it. We walked through the halls of Congress, delivered 75 copies of the manual. Of course, we think it's the greatest thing ever, or the greatest new thing ever. And you get mild interest. We met some really high-ranking players in this whole debate. The head of the Republican policy, I'm trying not to get too specific here, but the person in charge of writing off on their stuff, yawned. And, we've got to get their attention. It's got to come from grassroots. But it is politics. Okay, so I got to criticize a little bit. You look at the policy handbooks, they're great ideas. They're absolutely great ideas, little pieces of the puzzle that can fit together. I've worked on them here in Minnesota. We have a great, really, really, really good health plan combination kind of thing here in Minnesota. But politics stops it. And you could point a lot of fingers. Getting reelected is pretty important. That's one. The people who are financing campaigns, certainly they have a voice. The lobbyists who have the ear of the legislators, they have a voice. And I'm not for beating up on insurance companies, but I can tell you the ratio between insurance company lobbyists and even health underwriters, in Minnesota, you have one paid lobbyist that's opposing about 42 on the payer side. So who's getting the attention? That's why politics. And what's going to happen if this? I think this is getting critical. So if we don't, at $20,576 already for average premium, we're coming to a point, I think, where something has to change. Why does it take? We studied a lot of foreign healthcare systems, and we saw it was about a 40-year cycle from the time when they passed their first, we can do everything national plan to when they started watering it down. Here, for some reason, it's taken us a long time. Politics.
Yeah. Well, Larry Greenberg actually put a comment in the Q&A as you were talking there. It says it's easier to get elected when you promise freebies. And
yes,
that's
yes,
that's pretty universal right there. Actually here, Mike Reichus has asked another question, or maybe a comment that you can comment on. Sure. Of those 5 carriers that have 82% of the market, how many of those are owned by or have close relationships with care systems?
I'm going to actually have to say I don't know. I know a couple of them have PBMs and pharmacy systems. I know one of them I had read had 22,000 physicians in primary clinics. That's maybe a year or two old statistic. So, my guess is a lot. Mm-hmm. And this is another pernicious problem. Hate to keep saying Minnesota, but 20 years ago, we broke up a health provider from a health insurance company, just broke it all off. And today, when you come here, you wouldn't know that happened because payers, providers under the same roof. Maybe that's a conflict.
Yes. Okay. Well, Thomas Houck has a question for you, Dave.
Okay.
He asks, how does Mr. Racer's plan compare to President Trump's executive order on improving price and quality transparency?
Well, the executive order, as I understand it, requires hospitals to disclose their prices, and that's a really, really good step forward. You ought to go and go on a hospital website, see if you can find it, first of all, because it's really, really hard to find these things. I mean, I know I was searching for them. Secondly, get the list and look at it, and then see if you can find a procedure on there that makes any sense to you and figure out the price. That's the problem with it. This is not to be cynical. It's a great step forward. But when you call Regent's Hospital and you say, what percent do you accept as payment in full? And they say 220%, and you call North Memorial and it's 180%. Now you have some data you can work with. But to call and try to explain, the procedure by name or whatever, and the spread is huge. We have a procedure like a knee replacement in Minnesota, or hip replacement. Some of you won't like this number, but it is what it is: $6,666 to $43,000 for the same procedure. Which one is the lower percent of Medicare? And maybe you wouldn't want to go there, but you might want to go to the one that's 140%.
Yeah. Well, there seems to be this, I think one of the barriers to empowering patients to make choices is that our government and our society doesn't seem to trust Americans to be able to make these decisions. And so they want it left up to government. Is that true?
Yes, I think it absolutely is. And I hate to say it, even on that, it's a political divide. And I'm Jim, I'm not trying to get partisan here. And I won't, I promise. I have a little experiment, a sociological experiment I'm running right now. I invite about 30 of my Johnson High School class of 65 friends to lunch every once in a while. And right now I'm getting Republicans saying yes and Democrats saying no because of masks, and they're afraid to come out. I mean, it's absolutely bizarre. So for some reason, our politics just clouds our partisanship, clouds our ability to find good solutions, and they are there. I mean, this is one of them.
Mm-hmm. Yes.
I didn't get you into trouble on that, I hope.
No, I don't think.
My sociological experiment.
Yes. Well, there are other questions out there. There's no pending question at the moment. I see, I will say that I'm scrolling through the names of the people that are here, and I am very encouraged to see the names of a lot of regulars that have come to this office in the past. So and this is great. This entire presentation actually is being recorded. It's live streaming on YouTube right now, and we will be also posting this entire presentation so that and let everybody here on the call know, so you can share it with friends. I think it's been a fantastic conversation so far as we come up to our 1 hour mark pretty soon. Steve Helms has a question for you though, Dave.
All right.
He says, is this percentage an average, or do the providers take one percentage for all procedures?
Well, the way it works in Minnesota, and I'm going to just spin off of that to answer the question, what we're actually showing is the average amount. This is what the law required. The average amount they accept as full payment of all the carriers. So some carriers at $100 and some are at 120 and some are at 80. So you get an average 100. So that's the way it works now. We're getting away from that completely. We're saying, what percentage do you accept? And yeah, they are going to have to restructure, the providers are going to have to restructure their system in order to accommodate that kind of concept, not an average across the board, but what will they take in their system? Mm-hmm. And like anything, there's things that maybe are 125% today, and there's others that are 500%, and they're going to have to find a happy medium in there somewhere, but they're going to have to compete on that. We also have a provision, Jim, that limits like subcontractors isn't the right word, subspecialists, like in the surgical centers where you have, you go in for a procedure and an anesthesiologist charges you 1,350% of, I apologize to you if you're on the call here, charges 1,350% of Medicare, while the hospital, is more like 300%. And then you get the surprise billing, and the agents on here can attest to this. There's a lot of incidents of that. And we're saying, no, you've got to have 1%, and everybody in that procedure has to be at that percent.
Mm-hmm. We got another question here from Karen Crotty again. Do you think we would ever get the dental community in on this?
Well, they might get a better return if they did. We didn't discuss dental, honestly. So throw that back at it and send me an email, and I'll get going on that.
Well,
same with chiropractic. We don't have that on there, but I suppose it's easy to adapt.
Yeah, John Taylor here left a comment where he says, "Would be happy to see Dave in New Jersey!" Exclamation point. I'm a plastic surgeon in private solo practice, trying my best to buck the forces that try to control us.
Great.
And I think putting that with the dental question, and then you just mentioned chiropractors. I mean, there seems to be, then you have direct primary care, and there is a lot more diversity in the healthcare field than most people realize.
Yeah.
And I wonder if you could give Dave and other doctors and healthcare providers some advice on how they can best buck the forces that try to control their industry.
Yeah, and my mind wandered for a second. It does that a lot. The gentleman that just said that, was he plastic surgeon? Is that what he said?
John Taylor, yeah, plastic surgeon in private solo practice in New Jersey, yeah.
So, and he's been doing that for a long time. I think there's evidence that direct pay practice is possible, coming from his profession and from LASIK surgery, and actually there's quite a few things like that. But there is a movement across the country, nascent movement. It's not a big one. That applies probably more easily to primary care, family practice, and actually outpatient surgical, like at the Oklahoma Center and others that are coming online now for direct pay. There has to be a lot of incentive for, frankly, the people who are paying the bills to really want to do that. There are insurance companies who are really comfortable with that now. I don't know who they are. The agents on here would know that better. The courage to do it is another thing now. Kind of an odd application. I'm a homeschool granddad now, and we homeschooled our kids, and I teach kids at an academy for homeschoolers, right? And right now we have this huge number of people who are schooling at home. And why am I telling you this? There's a difference between homeschooling and schooling at home. Homeschool parents and kids have a really different view on this whole thing. And I think it's true. This is what I'm trying to say with medical providers. And I don't even like the word provider. Please forgive me, wash my mouth out. For physicians and surgeons, there has to be a mindset. I mean, it's a rugged thing. I've written books with direct pay payers, Passion for Patients, which I did talk about at Heartland, a new book with a doctor in Ohio, direct pay doctors. You got to have it in you to want to be an entrepreneur, to want to be independent. And I don't know Dr. Taylor, I don't know about his age or whatever, but we learned that a lot of the older doctors really cherish that independence. It's very important to them, but not so much with the younger doctors who are coming out of medical school and going into healthcare systems, or factory medicine, as I call it. And so, first of all, it's not everybody, it's not every physician that wants out and that could do it. Wants out, what am I saying? Wants into independent practice. They couldn't all do it. It's a mindset. And it's a commitment, it's a financial commitment, because you don't have that company behind you ready to claw back the money they paid you last year. That was a little cynical, I know. You're on your own, and patients don't come in the door. I'm kind of curious what's happened with some of the direct pay doctors with COVID. And you hear it. I've done a lot of work on COVID, okay? You hear it a lot from the doctors. They're really concerned about the patients that haven't been coming in. You want to see an uptick in deaths in the next 6 months from cancer or cardiac disease or diabetes or on and on. It'll probably say COVID on the death certificate, but that's not true.
Hmm. Well, yeah. Speaking of doctors, the people have warned. Well, since if you implement Obamacare, if you have Medicaid for all, if you have price controls, there's been talk about there being a possible shortage of doctors, a doctor shortage, that people will not go into the profession, or they will retire early because it's not worth the aggravation. Again, if there was a true free market healthcare system, it would be a vibrant market in which people would want to get into it, right? Do you worry? Do you think that's overblown, the idea of a potential doctor shortage in the next decade or two?
Absolutely not. I have befriended some wonderful physicians and surgeons, and one that I really, really like is in his early 40s. He's an entrepreneur. He's a dermatologist and does very, very well, but has already said, I'm getting out of this. I'm not staying in this. I'm not putting up with this. He's planning his exit, and he's just in his early 40s, and he's been independent. I think that is unfortunately what's going to happen. And you're seeing, in a way, a dumbing down, if you will. Oh, golly, that's a qualitying down. I don't even know the words. Even going to telehealth, and some of you are going to say, wait a minute, telehealth's a great idea. Doctor can't see you. He can't touch you. He can't, he needs to be in the room with you to get really good healthcare. That's informed by all my doctor friends, okay? But it is a way to reduce the price of healthcare. Using lesser trained individuals. I think you're going to see an increase in that anyway. You're certainly seeing it. They're using COVID, I think, as a way, and this is not sinister conspiracy. It's just they're using it as a way to increase telehealth acceptance of it. My opinion, observation.
Okay. Well, we that's good. Thank you.
See what I said?
Yeah. I always like to end on a high note, Dave. You know that. On a positive note, I will ask the group if there are any other questions here for our speaker, Dave Racer. Going once, going twice. Okay. Well, as noted, Dave Racer is not hard to find. You can go to daveracer.com. You can email us here at think@heartland.org, where you can get copies of his new book. And also, we can serve as a conduit between you and Dave if you want to have more personal conversations via email with him and his ideas, and share some ideas and get some advice. Frankly, he really knows what he's doing on this subject. And we'd also like to hear from you people that were on this special webinar for us today with Dave Racer. What was the experience good for you? Did you enjoy it? We picked the middle of the afternoon at 1 p.m. Central Time because we thought it might be a good, maybe people are at lunch. So is the time 1 p.m. good for you? Would you rather have something like this in the evening? What other kind of speakers would you like to have come join you online here at the Heartland Institute to present? And what topics would you like to listen to? We're open to all of those ideas. We want to make sure that we are continuing our fight publicly for free markets, more individual liberty, and but basically free markets, so that there's lower prices in places like healthcare, that there's freedom to choose, and that we all have more liberty. That's what the Heartland Institute has always been about. And we appreciate all of you being on the call today, and we hope to see you again next time. Thank you, Dave Racer, for being with us.
Thank you.
Bye, all.